Hey everybody, Dr. Rayford here from Vet Triage. We are continuing through this issue of Veterinary Surgery, November 2024. We are talking about the use of a free proximal ulnar autograft for ipsilateral radial lengthening in a dog with a short radius and subsequent elbow incongruity. This study comes out of the Specialty Center and Emergency Hospital in Texas, Austin. The objective is to report this technique and outcome of proximal ulnar autograft transplantation. Where is it here? To achieve ipsilateral radial lengthening in a dog with premature closure of both proximal and distal radial physes. It's a case report of one dog, 8-month-old female border collie. Radiographs showed a 7% length deficit of the left radius and elbow subluxation, indicative of left elbow incongruity due to suspected premature closure of both radial physes. Radial lengthening consisted of a proximal ulnar ostectomy. So you can see here they removed the proximal portion of the ulna there. A radial osteotomy, so they made an incision in the radius itself. And then transplantation of an ulnar autograft onto the radial osteotomy site secured with 8-hole dynamic compression plate, and that's the metal you see here. Results found lameness improved, complete resolution by 3 years. X-rays at 4 weeks showed persistent lengthening of the radius of 1 centimeter and a decreased humeroradial index, decreased humeroulnar index, and radioulnar index compared with previous. At 3 years, the humeroradial index and the humeroulnar index had increased, indicating progression of elbow incongruity, but the patient was doing fine. Conclusion was that in dogs with radial shortening and elbow incongruity, use of an ipsilateral proximal ulnar autograft with rigid internal fixation can be effective for treatment for radial lengthening to improve elbow congruity and resolve lameness. So before we go into this paper, the next few videos from veterinary surgery are going to be case reports or very small case series. These are most useful for two things. Number one, for interns, residents, new doctors who want to have who want to get a basic knowledge of the literature search, because these are papers that are good about recapping what the current literature has been, or rather prior literature has been. It's also important especially for surgery residents, where when they describe a new repair, surgical repair or surgical treatment, it's now included in your list of surgical techniques that can be used as an answer to a question on the examination. So this would be one of those situations. Otherwise, these papers are not very good for actual statistical analysis, but they also don't promise that either. They're obviously case reports. Introduction: premature physeal closure in dogs can occur due to growth plate trauma, infection, nutritional deficits, and developmental factors such as retained cartilaginous cores and chondrodysplasia. This leads to asymmetric growth of the affected bone, joint incongruity, secondary arthritis, angular limb deformity. Injury to the distal radial physis, although less common than distal ulnar physeal injury, produces a short radius and a widened humeroradial space. In dogs with asymmetric premature closure, varus or valgus deformity of the carpus in relation to the radius and ulna may also be appreciated, with the types of angulation dependent on the location of premature closure. Once skeletal maturity is achieved, surgical treatment for a short radius aims to restore humeroradial articulation via radial lengthening osteotomy and or ulnar shortening ostectomy. Radial lengthening techniques can be static and acute or dynamic and more gradual. Such techniques for static include stair step, oblique with bone sliding, and transverse radial osteotomies. There's also a novel canine elbow realignment osteotomy implant system that have been used for acute radial lengthening in a cadaver incongruency model and may be clinically applicable to elbow incongruity in the future. A study described an acute radial lengthening technique for dogs with premature closure of the distal radial physis, utilizing a segment of ulna transposed into a radial osteotomy site. Ulnar autograft transposition has been reported in dogs for limb-sparing techniques with distal radial osteosarcoma and for resected mandibular tumor. The aim of this report was to describe the use of a free ulnar autograft for ipsilateral radial lengthening in a dog with premature closure of the radial physes to improve elbow congruity. This technique avoids the use of specialized instruments or systems often necessary for complex orthopedic surgery and may provide a more accessible method of radial lengthening for the surgeon. So I'm going to show you this image and talk about the description here. So there's a first set of radiographs, obviously comparing the abnormal left side with the normal right side. So in these images, we have the left radius is 1.1 centimeters shorter compared to the right. Left ulna 0.6 centimeters shorter. There is humeroradial and humeral-ulnar incongruity with humeroradial subluxation. Both the proximal and distal radial physes have reduced conspicuity relative to the contralateral limb, and radiocarpal incongruity is present. The right limb is normal. So the right radius measures 13.2 centimeters, whereas the abnormal left radius is 12.1 centimeters, equaling a percent length deficit of 8% relative to the contralateral radius. The right ulna measured 16.3 centimeters, left was 15.7 centimeters, resulting in an ulnar length deficit of 8 millimeters or 3.6%. Calculations using best fit circles revealed a left-sided central humeroradial distance, a central humeroradial distance, and a central radio-ulnar distance of 3.5, 3.8, and 6.5 millimeters, respectively. These distances resulted in an humeroradial index, humeral-ulnar index, and a radial-ulnar index of 0.6, 0.6, and 1, respectively. The reduced conspicuity of the proximal and distal radial physes relative to the contralateral limb likely indicate premature and asymmetric closure. Recheck radiographs 1 month later revealed mild growth of both left and right radii and ulnae, or ulnas, closed radial physis, and persistently short left radius. As well as progressive elbow incongruity. Left-sided humeroradial distance, humeral-ulnar distance, and radio-ulnar distance equated 4.2, 6.1, and 8.8 millimeters respectively, resulting in a humeroradial index, humeral-ulnar index, and radio-ulnar index of 0.7, 1, and 1.4 respectively. Right-sided central distances and subluxation indices were also measured for normal comparison. The right side humeroradial distance, humeral-ulnar distance, and radio-ulnar distance measured 1.5, 0.9, and 1.9 millimeters respectively, resulting in a humeroradial index, humeral-ulnar index, and radio-ulnar index of 0.2, 0.1, and 0.3 respectively. The right and left radii measured 13.5 and 12.5 centimeters respectively. The right and left ulnas now equal at 16.6 centimeters. The radial percent length deficit was 7%. 15-degree left carpal valgus deformity also developed with a lateral distal radial angle of 73 degrees compared with the right side of 88 degrees. And so this image I'm going to show you now, the x-rays, the left elbow joint remains abnormal with humeroradial and humeral-ulnar incongruity, humeroradial subluxation, and secondary arthritis. Carpal valgus, shown in blue, is present. Left radius is short with 1 centimeter length deficit. There's no longer ulnar deficit. Left proximal and distal radial physes are closed. And this is the image we're talking about right here. There you go. As you can see, the blue line shows valgus. And then we have more radiographs. Improved, this is after surgery, improved radio-ulnar and humeral-ulnar incongruity and persistent carpal valgus. The new radial length is 13.5 centimeters, which is equal to the normal side. And then this other picture shows an infection of the incision that occurred sometime later. So there's the x-rays there. Sorry, the glare. So surgery, the interosseous ligament was transected, the ulnar ostectomy was performed, and the section of ulnar removed, transverse osteotomy of the proximal radius, 8-hole 2.7 millimeter dynamic compression plate, proximal radial segment with 2.7 millimeter cortical screws. The ulnar graft was secured to the proximal radial segment with a 2.7 millimeter cortical screw placed through the plate. The distal radial segment was reduced and the remaining 4 2.7 millimeter cortical screws were placed. Bone reduction and alignment were appropriate. Results: immediate postoperative orthogonal radiographs revealed appropriate implant positioning and lengthening of the radius from 12.5 to 13.5 centimeters. So all this work just to get 1 centimeter length of the radius. So this one screw here is in the ulnar graft. Elbow incongruity was improved with a decreased central humeral radial distance, humeral ulnar distance, and radial ulnar distance of 3.5, 5.1, and 7.7 millimeters respectively, resulting in a decreased humeral radial index, humeral ulnar index, and radial ulnar index of 0.6, 0.8, and 1.2 respectively. At 4 weeks, radiographs showed appropriate radial lengthening at 13.5 centimeters. The central humeral radial distance, humeral ulnar distance, and radial ulnar distance were decreased at 1.7, 2.0, and 3.5 millimeters respectively, resulting in a decreased humeral radial index, humeral ulnar index, and radial ulnar index of 0.3, 0.3, and 0.6 respectively. Carpal valgus was still at 15 degrees. Goniometry revealed comparable flexion and extension of both elbows at 30 and 60 degrees respectively. Implants looked good. Complete radial union. Radial ulnar synostosis was appreciated with progression of elbow incongruity, although the congruity was still improved compared to preoperatively. The central humeral radial distance, humeral ulnar distance, and radial ulnar distance were now 2.0, 2.5, and 3.6 millimeters, respectively, resulting in a humeral radial index, humeral ulnar index, and radial ulnar index of 0.3, 0.4, and 0.6. Measuring the right limb was unchanged, with a humeral radial distance, humeral ulnar distance, and radial ulnar distance measuring 1.5, 0.9, and 1.9 millimeters, respectively, and the humeral radial index, humeral ulnar index, radial ulnar index 0.2, 0.1, 0.3, respectively. Other radiographic findings include ulnar disuse atrophy and subtrochlear lysis. And so we're going to show you these radiographs here. These are what we're looking at now. For this side, this is 3 years after surgery. The ulnar graft is completely incorporated, so this area here is all smoothed out. The radial length is improved and the implants are unchanged. The implants look good. The radial length is the same. Radial ulnar synostosis, which is the green arrows here, is just fusion of the radius and ulna. Progressive secondary humeral radial and humeral ulnar incongruity compared with previously. Carpus valgus is still there. Disuse atrophy of the ulna. So this happens, the ulna gets thinner distally because the implant is so strong that the body has no reason to keep the ulna around, and so disuse atrophy occurs. Discussion. The use of ulnar autografts has been reported in the veterinary literature, specifically for the treatment of distal radial osteosarcoma, en bloc resection of the distal radial osteosarcoma with subsequent use of a free proximal cortical ulnar autograft stabilized with a pancarpal arthrodesis. Additionally, ulnar rollover transposition has been described in dogs with distal radial osteosarcoma, in which the vascular supply of the autologous cortical ulnar graft is preserved to maintain viability. These procedures have high complication rate, implant failure, loss of graft viability, incomplete and inconsistent healing, infection, radial fractures, and recurrence of primary disease, but limb function is acceptable. Other radial lengthening procedures include a stair-step radial osteotomy for static lengthening to improve elbow incongruity, oblique and transverse corrective radial osteotomies, distraction osteogenesis, linear and circular external skeletal fixation have been used, although complications are common, including pin tract infection, pin breakage, pain, muscle contraction, non-union, damage to cartilage, or neurovascular structures. If radial length discrepancy is minimal, a dynamically stabilized ulnar osteectomy proximal to the radial ulnar ligament can improve elbow incongruity without the need for radial lengthening. This procedure allows for distal movement into the medial coronoid process to restore contact area continuity across the radial ulnar articulation. Formation of the radial ulnar synostosis has been contributed to the mild progression of elbow incongruity postoperatively. Additionally, the synostosis and stress shielding from the radial implant may have caused redistribution of load leading to disuse atrophy of the distal ulna. Due to the procedure, including both radial and ulnar osteotomies, the rate of radial ulnar synostosis formation may be higher in most, if not all, patients who undergo this procedure. CT scan or arthroscopy for assessment of elbow dysplasia is important. For CT scan, the reported mean sensitivity for elbow congruity in dogs is 88.8% with a mean specificity of 91.7%. And also they say they could have used force plate gait analysis for the lameness as well to make the case more objective. So for veterinarians, just be aware that there's pretty cool procedures out there for these angle limb deformities, premature closure of growth plates, limb disparities, and then secondary joint issues. And then for pet owners, just because your dog has a limb that's kind of on the wonky side, there are ways that we can diagnose these patients and try to treat them, albeit it may not be as good as a normal leg, but you can get good improvement, especially in the right hands. All right, we'll see you guys again for the next video. Bye-bye.